Welcome back to the deep dive. Today, we are opening up a file that honestly I think usually scares people away a little bit.
Hmm.
It is dense, it's very chemical, and it deals with some of the darker parts of the human experience. We are looking at Chapter 25 of Brenner and Stevens' Pharmacology, the 6th edition.
The drugs of abuse chapter.
Yeah.
Yeah, it's a heady hitter.
It is. And I think when most people hear drugs of abuse, their minds immediately pivot to the social side of things.
Sure. Crime, legislation.
Exactly. We think about crime, we think about legislation, maybe we think about gritty TV dramas or the headlines we see every single day. We have all these, cultural narratives built up around the topic.
Right.
But the mission for today is to strip all of that away.
Completely. We are leaving the sociology lecture hall and walking straight into the biochemistry lab.
We are going to put on the white coats and look at this strictly as mechanics. We just want to know, what is the molecule doing?
Which receptor does it hit?
Why does the brain react the way it does? And most importantly, and I think this is where the text really shines, we want to understand the why behind addiction.
And not the psychological why.
No, the biological why.
It's such a crucial distinction. The text emphasizes right from the start that we need to separate abuse as a medical concept from abuse as a legal or social one.
This was the first big surprise for me in the reading. I think most of us assume drug abuse just means using illegal drugs,
That's the common vernacular, absolutely.
If it's banned, it's abuse. If it's sold at the corner store, it's fine.
But medically, Brenner and Stevens define abuse much more broadly, and I think much more accurately. They define it as the use of any drug in a manner that is detrimental to the health or well-being of the user or to society.
Which puts a very, very different spin on things.
It has to,
Yeah.
because under that medical definition, the text explicitly points out that the two biggest abused drugs in the United States are, well, they're alcohol and tobacco.
Which are completely legal.
Legal, socially sanctioned for the most part, but in terms of health cost, organ damage, and societal harm, they fit that definition of abuse perfectly.
So legality is not the metric we're using today.
Not at all.
Harm is the metric.
Precisely. And that's the lens we need to wear for the next hour or so. We aren't judging the user, we are analyzing the physiological state.
Okay, so before we get into the specific drugs, and we are going to cover everything from alcohol to heroin to bath salts, the whole gamut, we have to nail down the terminology.
Yes.
There are 3 words that get thrown around interchangeably in casual conversation, but in pharmacology, they mean 3 very, very different things. Addiction, physical dependence, and psychological dependence.
These are the absolute pillars of the chapter. If you don't get the difference here, the rest of the pharmacology it won't make sense.
So where do we start?
Let's start with physical dependence. The text uses a very specific term for this I think is brilliant. Neuroadaptation.
Neuroadaptation. That sounds like the brain is, upgrading itself.
Or maybe just desperately trying to survive. Think of it like this. Your body is obsessed with homeostasis.
Balance.
Total balance. It wants the temperature to be 98.6 degrees. It wants the heart rate steady. Now imagine you are constantly flooding your system with a chemical that, say, slows your heart rate down.
Like a depressant. You mentioned alcohol or maybe opioids.
Right. If you do that every single day, your body eventually says, okay, clearly this chemical bath is the new normal. This is the new environment I need to adjust. So it changes its own internal mechanisms to counter that drug. It pushes back to try and find a new equilibrium that includes the drug.
Wow. So the drug becomes a load-bearing wall in your physiology.
That is a fantastic way to put it, a load-bearing wall.
Yeah.
And that explains the hallmark sign of physical dependence, withdrawal.
Right.
If you suddenly remove that load-bearing wall, if you stop the drug, the building collapses. The body has adapted to function with the drug. Without it, you get a withdrawal syndrome, which is, interestingly, usually the exact opposite of what the drug does.
So if the drug makes you sleepy and, say, constipated.
Withdrawal makes you agitated, gives you insomnia and diarrhea.
Okay.
And this drives what psychologists call negative reinforcement. This is a really key concept. At this stage, you aren't taking the drug to feel good. Not anymore.
You're taking it to stop feeling bad.
You are taking the drug just to feel normal, to stop the pain of withdrawal.
That's terrifying. It's a physiological trap.
It is. Now let's contrast that with psychological dependence.
This is the want, right? This is different.
This is the want. Yes. This is driven by positive reinforcement. You take the drug because it produces pleasure or stimulation or maybe a necessary escape from reality. The text notes that this is often the driver in the early stages of use. You learn that action A, taking the drug, leads to result B, feeling euphoria.
A simple learned
The
behavior.
first. And then we have the big loaded word, addiction.
Right. And the text defines addiction as the extreme end of this whole spectrum. It's an extreme pattern of abuse.
So this is more than just wanting or needing. Oh, much more. We're talking about a continuous, all-consuming preoccupation with getting the drug, using the drug, and then recovering from the drug, to the point where you neglect your job, your family, your own safety. Everything else falls away.
But there's a note here in the text about the language itself, right? The authors seem to want to move away from the word addict.
They do, and it's a really important shift in modern medicine. Addict carries this pejorative, judgmental connotation. It sounds like a character flaw.
A moral failing.
Exactly. Modern medicine, aligned with the DSM-5, prefers substance use disorder, or SUD. It reframes the issue not as a bad person making bad choices, but as a patient suffering from a chronic, relapsing disease state.
A disease state. And to understand that disease, we have to go into the brain. We have to look at the wiring. Because the text describes something fascinating, a common neuronal pathway.
This is the dopamine hypothesis.
This blew my mind. I mean,
Right.
it doesn't matter if you're smoking a cigarette, drinking a beer, or shooting heroin. Chemically, those are wildly different substances.
Totally different.
But the text says they all end up ringing the exact same doorbell in the brain.
They do. It's incredible. They all converge on the mesolimbic dopamine system.
Okay, let's map this out for the listener. If I could shrink myself down, Ant-Man style, and stand inside the brain of someone taking a drug of abuse, where am I standing? What am I looking at?
You are standing deep in the midbrain, a really primitive part of the brain. Specifically, you want to look at a bundle of neurons that start in the ventral tegmental area, or VTA.
VTA, got it.
And they project, or, they send their cables forward into a region called the nucleus accumbens.
Ah, the famous reward center.
That's the one, exactly. This is the evolutionary engine of survival. This circuit creates the do-it-again signal. Normally, this pathway lights up for things like food, for sex, for social bonding, things that help the species survive. But drugs hijack this system. They hotwire it.
And the currency of this system, the chemical messenger, is dopamine.
Correct. But the text goes much deeper than just, it releases dopamine. That's the headline. The text explains the signal transduction pathway. This is the molecular chain reaction that happens inside the cell.
Let's trace it, because I think people hear dopamine and just think happy chemical, but it's actually a key that unlocks a very specific door, which starts a whole domino effect.
That's a perfect analogy. So we have dopamine floating in the synapse between two neurons. It travels across, and it hits a receptor on the surface of that nucleus accumbens cell, specifically the D1 receptor.
Okay, so dopamine rings the bell. Does it go inside the house?
No, it stays outside on the porch. It just presses the button. Inside the house, inside the cell, that button press activates an enzyme called adenylyl cyclase.
Okay, so dopamine rings the bell, adenylyl cyclase wakes up inside. What does it do?
It starts churning out a messenger molecule, a second messenger called CAMMP, that's cyclic adenosine monophosphate. The levels of CAMP inside that cell just skyrocket.
The signal is getting louder, the alarm is going off inside.
Much louder. This flood of CAMP then activates another group of enzymes called kinases, specifically protein kinase A. Now, kinases are like the construction foremen of the cell. They go around and chemically modify other proteins. They phosphorylate them, which is like putting a tag on them that says, get to work.
And where does this construction crew go? What are they building?
They go right to the headquarters. They move into the nucleus of the cell where the DNA is kept, the master blueprint, and they activate transcription factors, specifically one called CREB.
This is where it gets absolutely wild to me. Transcription factors literally control which genes get turned on and off. So you're saying taking a drug literally changes how your genes are being read.
It changes the blueprint of the neuron.
Yes.
When CREB is activated, it forces the cell to synthesize new proteins. It literally builds new structures. Specifically, one of the main things it does is increase the expression of glutamate receptors on the cell surface.
So the physical structure of the brain is changing. It's remodeling itself.
It is strengthening that synaptic connection. And here is the absolute kicker. The text explicitly compares this process to long-term potentiation in the hippocampus.
Wait a second. The hippocampus is memory. That's where we learn things.
Exactly. The molecular mechanism for addiction is almost identical to the molecular mechanism for learning. When you abuse a drug, your brain is learning that drug. It is etching that need into its physical structure just as deeply and permanently as it etches your childhood memories or how to ride a bike.
That explains so much about why relapse is so common. You can't just unlearn something that has been physically built into your
You
neurons.
can. It's not a matter of willpower at that point. You
Yeah.
have to build new, stronger pathways around it.
The text has a visual figure 25.1 that shows a schematic of a rat brain, and it distinguishes between drugs that act directly on this system and ones that act indirectly. What's the difference there?
Yeah, it's about how they get the dopamine flowing. The direct actors, like cocaine and amphetamines, are blunt instruments. They go straight to the nerve terminals in the nucleus accumbens and either force dopamine release or block its recycling.
They kick the door down.
They kick the door down.
Correct.
But then you have the indirect actors. This is opioids, nicotine, alcohol, marijuana. They're sneakier.
How so?
They work via interneurons, specifically GABAergic neurons.
And GABA is the brake pedal of the brain, right? It's inhibitory.
The primary brake pedal, yes. Normally, these GABA neurons act as a brake on the dopamine system, keeping it from firing too much, keeping it in check. The indirect drugs, what they do is they shut down the GABA neurons. They inhibit the inhibitor.
They cut the brake line.
That's it, exactly. They cut the brake lines, and with the brakes gone, the dopamine neurons start firing uncontrollably. Same result, a flood of dopamine, but a much more roundabout way of getting there.
Before we leave these core concepts, we have to talk about speed. The text makes a big point that pharmacokinetics, how the drug moves through the body, is huge for addiction potential. Why is smoking a drug so much more addictive than swallowing it?
It all comes down to the rate of dopamine increase.
Yeah.
The brain pays very close attention to sudden, dramatic changes,
A steep curve.
a very steep curve. If you take a drug orally, it has to go to the stomach, then the intestine, then get absorbed, go through the liver. It's a slow rising tide. It might take 30 minutes.
Gentle slope.
Right. But if you inject it intravenously or you smoke it via inhalation, it bypasses all that. It hits the brain in, 7 to 10 seconds? It's a tsunami of drug.
Wow.
And that rapid, massive spike creates a much, much more powerful reinforcement signal. The brain goes, whoa, what was that? Do it again now. That's why the route of administration can change the entire addiction profile of a substance.
Okay, so we understand the machine, we know the wiring. Now let's look at the different kinds of fuel. The text breaks the drugs down by class, and the first stop is section 2, CNS depressants.
And the undisputed king of depressants, ethanol, alcohol.
The text puts this right at the top, and for good reason. It says alcohol abuse is the #1 substance abuse problem in North America. We're talking about 12 million individuals.
It's massive. And biologically, alcohol is a messy drug. It's a tiny molecule. It's water-soluble. It goes everywhere in the body.
And its metabolism is weird. The text mentions something right off the bat regarding zero-order kinetics. Can we break that down? Because I think most drugs don't work this way.
You're absolutely right. Most drugs follow what's called first-order kinetics. That means your liver processes a certain percentage of the drug per hour, say 50%. So if you have 100 units of a drug, an hour later you have 50, another hour later you have 25. The more you have, the faster your liver works to clear it.
It scales up. It's efficient.
It's efficient. But alcohol is different. Alcohol follows zero-order kinetics.
What?
This means the liver encounters a bottleneck. The enzymes, specifically alcohol dehydrogenase, get saturated almost immediately.
Okay, so the workers on the assembly line are at full capacity. They can't take any more boxes.
Exactly. They are completely overwhelmed. So the liver can only process a fixed amount per hour, regardless of how much is in your blood. For the average person, that's about 10 milliliters of absolute ethanol per hour. That's roughly one standard drink.
So if I drink 1 beer in an hour, my liver can basically keep up.
It can handle it.
But if I drink 5 beers in an hour,
Your liver still only processes one of them. The other 4 are now stuck in a traffic jam in your bloodstream. They just keep circulating to your brain, your heart, your tissues. That backlog is what causes your blood alcohol concentration, your BAC, to spike.
that's a crucial safety insight. You literally cannot speed up sobering up.
You cannot.
Coffee doesn't do it. Cold showers don't do it.
It is physically, enzymatically rate limited. You just have to wait.
Let's look at the chemistry of that breakdown, because figure 25.2 in the text shows a pathway that looks simple on the surface, but it has some really nasty byproducts.
It's a two-step process.
Yeah.
Step 1. Ethanol is converted into a molecule called acetaldehyde. This is done by that enzyme we just mentioned, alcohol dehydrogenase.
Acetaldehyde, that just
Yeah.
sounds toxic.
It is highly toxic. It's a carcinogen. It's a very reactive molecule. It damages proteins. It damages DNA. It is responsible for that facial flushing some people get when they drink, and a lot of the nausea and headache of a hangover.
Yikes. So how does the body get rid of it?
Usually, very quickly, the body moves to step 2, converting that toxic acetaldehyde into harmless acetate, which is basically vinegar. That's done using a second enzyme, aldehyde dehydrogenase.
But the text mentions there's a cost to doing business here. To run this whole factory, the liver has to use a specific fuel source, a coenzyme called NAD.
Nicotinamide adenine dinucleotide.
Yes. This little molecule is absolutely vital for all sorts of metabolic energy production. But when you binge drink, your liver has to divert all its available NAD just to break down the alcohol. It creates a massive NAD deficiency for all other functions.
What gets neglected when all the NAD is being used up? Fat metabolism, that's the big one. Normally, the liver is constantly burning fatty acids for energy. But that process requires NAD. Without it, the process grinds to a halt. The fat has nowhere to go, so it just accumulates inside the liver cells.
And that's fatty liver.
That is the very first acute stage of alcoholic liver disease. So you see, it's not just some vague toxicity, it's a resource management crisis inside the cell caused by NAD depletion.
Now, what about the brain? We call alcohol a depressant, but after 1 or 2 drinks, people are often loud, they're dancing, they're more social, they don't look depressed.
That's the paradox of disinhibition. Alcohol acts on GABA receptors to potentiate GABA. And remember, GABA is the brake. So alcohol essentially presses down hard on the brake pedal of your frontal cortex, the part of you that is responsible for judgment, planning, and social inhibition.
So it sedates the part of the brain that cares about consequences, the don't dance on the table part.
Exactly, the don't say that to your boss part. At the same time, it inhibits NMDA glutamate receptors. Glutamate is excitatory. It's involved in forming memories. When you block that, you get sedation and amnesia, the blackout.
The long-term effects listed in the text are just brutal. It specifically calls out Wernicke-Korsakoff syndrome.
This one is particularly tragic because it's completely preventable. Alcoholics often have terrible diets, but alcohol also actively inhibits the absorption of thiamine, which is vitamin B1.
Okay.
And thiamine is absolutely essential for neurons to function, to make energy. Without it, the neurons literally starve and die, particularly in areas of the brain critical for memory and coordination.
What are the symptoms to look for?
It starts as Wernicke's encephalopathy, a classic triad of confusion, ataxia, which is a stumbling, uncoordinated walk, and ophthalmoplegia, a paralysis of the eye muscles. If that's not treated immediately with high-dose 5-thiamine, it can progress to Korsakoff psychosis.
And that's
Irreversible. Profound memory loss. Patients will confabulate. They make up detailed but false stories to fill the gaps in their memory because the recording tape in their brain has been permanently erased.
Before we leave alcohols, we have to mention the toxic alcohols. These aren't the ones you buy at the liquor store.
No, this is methanol or wood alcohol and ethylene glycol, which is antifreeze. The danger here isn't the alcohol itself, but the metabolites. The body uses the same enzymes to process them as it does for ethanol, but the result is disastrous.
What happens with methanol?
It gets metabolized into formaldehyde, which is embalming collided, and then into formic acid, or formate. Formate has a bizarre and specific toxicity for the optic nerve. It destroys it. It causes permanent blindness.
And antifreeze, ethylene glycol.
That's metabolized into oxalic acid. This binds with calcium in your blood to form sharp, needle-like calcium oxalate crystals.
Oh.
These crystals form in the kidneys and just shred the renal tubules. It causes acute, often fatal renal failure.
The treatment mentioned in the book is fascinating because it involves basically fighting fire with fire.
Oh, it does. You can actually use regular ethanol, whiskey or vodka or IV ethanol in a hospital as an antidote.
How does that work?
Because alcohol dehydrogenase, that first enzyme, has a much higher affinity for ethanol than for methanol or ethylene glycol. So if you flood the patient's system with ethanol, the enzyme gets busy working on that instead.
It distracts the enzyme.
It completely occupies the enzyme. It's a competitive substrate. This gives the body time to excrete the toxic alcohols safely through the kidneys before they can be turned into those deadly poisons.
Okay, let's move to the next part of the chapter, section 3. Other CNS depressant sedatives and opioids. We covered barbiturates and benzodiazepines as therapeutic drugs in a previous deep dive, but here we're looking at them through the lens of abuse.
And the mechanism is similar to alcohol. They all enhance GABA signaling. They're often abused in combination with other drugs, which is where the real danger lies, polysubstance abuse.
The text flags 2 specific drugs here that are notorious, flunitrazepam and GHB.
Flunitrazepam is Rohypnol, infamously known as roofies. It is a benzodiazepine, but it's incredibly potent, it's tasteless, and it's odorless. And its key feature is that it causes profound anterograde amnesia.
Meaning you can't form new memories.
Correct. The victim has no recollection of events that occurred while they were under the influence. This is why it is so insidiously used as a date rape drug.
And GHB.
Gamma-hydroxybutyrate. It's an agonist at GABA-B receptors. It's known as a club drug. The really scary thing about GHB is the dose-response curve. It is incredibly steep.
What does that mean, a steep curve?
It means the difference in dose between feeling euphoric and being comatose and not breathing is a tiny, tiny amount. A capful versus a capful and a half. And mixing it with alcohol is often fatal because both are powerful respiratory suppressants. They act synergistically.
Speaking of respiratory suppression, let's talk about the opioid crisis. Section 3 dedicates a lot of space to this. Heroin, fentanyl, oxycodone.
Right. These drugs all act on the mu-opioid receptors. And for our purposes, they do three main things. They relieve pain, which is analgesia. They cause intense euphoria by disinhibiting dopamine, like we talked about. And they suppress the respiratory center in the brainstem.
That last one is what kills you.
Yes. In an overdose, you simply forget to breathe.
The text makes a specific point about heroin regarding its lipid solubility.
Yeah, this is key to understanding its appeal. Heroin is diacetyl morphine. It's basically morphine with two little acetyl groups stuck on. Those acetyl groups act like a greasy passport.
A passport.
They make the molecule highly lipid soluble so it dissolves in fat. That means it can pass through the blood-brain barrier incredibly fast, much faster than morphine can. And that speed, remember what we said about the importance of speed, creates the intense, immediate rush that drives the addiction.
And then we have OxyContin. This was a prescription drug, but the text notes a specific design flaw that directly led to its widespread abuse.
It does. OxyContin was designed as a controlled-release tablet. It contained a huge dose of oxycodone, but it was embedded in a waxy matrix that was supposed to dissolve slowly over 12 hours.
A trickle, not a flood.
That was the idea. But users quickly realized that if you just crush the tablet, you destroy the time-release mechanism.
You unlock the whole dose at once.
The entire 12-hour dose.
That's
Exactly. You could then snort it or dissolve it and inject it, getting 12 hours worth of a powerful narcotic in about 10 seconds.
The chapter includes a case study here, Ox 25.1, the case of the overdosed opioid addict. Let's walk through this because it paints such a vivid clinical picture.
It's a classic tragic presentation. A patient is brought into the ER, they're unresponsive, you check their vital signs, their breathing is slow and shallow, maybe 6 breaths a minute, and the physical exam shows the absolute telltale sign, meiosis.
Pinpoint pupils.
Pupils constricted down to the size of a pinhead. And then, of course, you might see needle tracks on their arms.
So the team immediately identifies it as an opioid overdose. The treatment is naloxone.
Trade name Narcan.
And naloxone is an antagonist. Let's explain what that means in this context.
Think of it like a game of musical chairs. The opioid molecule is sitting in the chair, the mu receptor making the patient high and stopping their breathing. Naloxone is a bigger, stronger player with a much higher affinity for the chair.
So it wants the chair more.
It wants more. It comes over, physically shoves the opioid out of the chair, and sits down itself.
But naloxone doesn't play the music?
Correct. Naloxone is a pure antagonist. It has no effect of its own. It just blocks the seat. And the result is what's sometimes called the Lazarus effect. The patient goes from nearly dead to awake and talking almost instantly.
But the case note says they often wake up angry.
Furious, belligerent, because you haven't just reversed the overdose. You have precipitated immediate, severe withdrawal. They go from a warm, fuzzy coma to intense pain, agitation, nausea, and diarrhea in the span of about 5 seconds.
And there's a crucial warning in the case study about the half-life.
This is a life or death point. Naloxone is very short-acting. Its effects might wear off in 30 to 60 minutes. But the heroin or fentanyl in their system might last for hours. So if you just reverse them and send them home, the naloxone wears off, the opioid climbs back into the receptor chair, and the patient stops breathing again. So they need to be observed for hours.
Absolutely. Until the opioid is cleared.
Let's shift gears. We've been talking about downers. Now let's talk about uppers. Section 4. CNS stimulants. Amphetamines and cocaine. Right? These drugs rev the system up. They mimic the sympathetic nervous system, the fight-or-flight response. The key players are norepinephrine and, of course, our old friend, dopamine.
But the way they increase dopamine is different. The text makes a really important distinction with a great diagram in figure 25.3 between the mechanism of amphetamine and the mechanism of cocaine.
It's a beautiful piece of molecular biology. Let's look at amphetamines first. They're like Trojan horses. They don't just work on the surface of the neuron. The dopamine transporter mistakes them for dopamine and actively pulls them inside the nerve terminal.
So they get into the cell.
They get into the cell. Once inside, they do two main things. First, they force dopamine out of its storage bubbles, the vesicles. Second, and this is the really wild part, they make the transporter protein run in reverse.
Wait, run in reverse?
Yes. So instead of sucking dopamine up to recycle it, the transporter starts actively pumping dopamine out into the synapse.
It turns the vacuum cleaner into a leaf blower.
That is the perfect analogy. It is actively flooding the synapse with dopamine.
Okay, now contrast that with cocaine.
Cocaine is much simpler. It's a blocker. It just binds to the transporter on the outside and plugs it up like a cork in a bottle. It prevents the reuptake. So the dopamine that is naturally released has nowhere to go. It just piles up in the synapse, hitting the receptors over and over and over again.
So amphetamine is an active pump. Cocaine is a passive plug.
Precisely.
The text specifically mentions crack cocaine. What is the difference between the crack form and the white powder form we usually see in movies?
It's all about chemistry and physics. The white powder is cocaine hydrochloride. It's a salt. Salts have high melting points, so you can't really smoke them effectively. That's why they're snorted.
Okay.
To make crack, you use a chemical process, often with baking soda, to strip off that hydrochloride molecule. You turn it into its free base form. The free base has a much lower melting point.
Which means it can be vaporized.
Yes, you can heat it and inhale the vapor. And because the lungs have a massive surface area for absorption, smoking gets the drug to the brain almost as fast as an IV injection. That crack sound it makes when heated is where the name comes from. The intense, immediate rush is what makes crack so much more addictive and dangerous than the powder.
There's a specific and very disturbing side effect mentioned for cocaine that gave me the creeps. Formication.
Cocaine bugs. Yeah, it's a tactile hallucination. The user has the distinct and horrifying sensation that insects are crawling on or under their skin.
Wow.
They will scratch and pick at themselves, sometimes for hours, until they have open sores and ulcers. It's a sign of high-dose toxicity and psychosis.
And medically, what is the most common cause of death for a cocaine user?
It's usually the heart. Cocaine creates a perfect storm for cardiac arrest. On one hand, it increases heart rate and the force of contraction, which means the heart needs more oxygen. But at the same time, it's a powerful vasoconstrictor, so it clamps down on the blood vessels feeding the heart, which means less oxygen supply.
High demand, low supply.
The worst combination. It can cause fatal arrhythmias and myocardial infarction, even in young, otherwise healthy people.
Moving on to Section 5, the stimulants we probably use to get this very deep dive written, nicotine and caffeine.
And nicotine is arguably the most addictive substance known to man if you measure by relapse rates. It is incredibly difficult to quit.
So how does it work its magic on the brain?
It binds to a specific type of receptor called nicotinic cholinergic receptors. These are found all over the autonomic nervous system, but crucially in the brain, they are located right on the neurons that control, you guessed it, dopamine release in the nucleus accumbens.
So it's another indirect actor cutting the brake lines.
Exactly. It causes a direct pulse of dopamine.
The text mentions something interesting about the dosing of nicotine. Smokers tend to smoke very frequently, a cigarette an hour or so. Why that pattern?
It's the pharmacokinetics. Nicotine from a cigarette puff hits the brain almost instantly because of inhalation. But then it rapidly redistributes to other tissues in the body, muscle, fat, so the concentration in the brain drops off very quickly.
The buzz fades fast.
Very fast. So the smoker feels the urge to light up again, to chase that peak brain level. It's a constant cycle of peaks and troughs.
And vaping, what does the text say about that?
The text notes that vaping, while potentially less harmful than burning tobacco tars, creates a new set of risks. You're inhaling a solution of nicotine in a solvent, often propylene glycol or ethylene glycol. When these solvents are heated to high temperatures, they can decompose into toxic compounds like formaldehyde. Plus, the concentrated liquid nicotine itself is very dangerous if it's spilled on the skin. It can be absorbed directly and cause poisoning.
Okay, what about caffeine? How does my morning coffee actually work to wake me up? It's clever. Caffeine is an adenosine antagonist.
Explain adenosine for us.
Adenosine is a natural byproduct of brain activity. As you go through your day, your neurons are firing, they're burning fuel, and they produce adenosine as a waste product. As adenosine levels build up in the brain, it binds to its receptors and signals the brain. We're tired, it's time to slow down. It acts as an inhibitory or drowsy signal. It inhibits dopamine.
So adenosine is the fatigue signal.
It's the sleep pressure signal. Caffeine's molecular structure looks a lot like adenosine, so it fits perfectly into the adenosine receptor, but it doesn't activate it. It just blocks it.
So it doesn't press the gas pedal, it just puts a block under the brake pedal.
That's a perfect description. It prevents the "I'm tired" signal from getting through to your neurons.
So you aren't actually less tired, you're just deaf to the signal that you're tired.
Exactly. And that's why when the caffeine wears off, all that adenosine that's been building up all day rushes onto the now unblocked receptors, and you get that characteristic caffeine crash. Section 6 of the chapter covers other psychoactive drugs. It's a bit of a grab bag. Let's start with the big one. Cannabis. Marijuana.
Right. The main active agent is delta-9 THC. And what's fascinating is that it mimics an endogenous chemical our own bodies make, a neurotransmitter called anandamide.
Anandamide. That's a beautiful word.
It comes from the Sanskrit word for bliss. And our bodies use anandamide to regulate things like memory, appetite, and pain. THC just comes in and hits those same receptors, the CB1 receptors, but much harder and for much longer.
Pharmacokinetically, marijuana is really unique because of where it hides in the body.
Yes, THC is extremely lipophilic. It loves fat. It gets absorbed from the blood and deposits in your adipose tissue. It just sits there.
For how long?
It can then leak out very, very slowly back into the blood over days or even weeks. This is why a urine test can be positive for THC long after the user feels any psychoactive effects.
The text addresses the gateway drug theory. This is always a politically and socially charged topic. How does this pharmacology text handle it?
The text is very objective and scientific here. It states that there is little direct scientific evidence to support the idea that marijuana used pharmacologically causes a progression to harder drugs.
And what about the motivational syndrome, the lazy stoner stereotype?
Similarly, it notes there isn't strong evidence for this as a distinct clinical syndrome. Correlation is not causation.
But it's not presented as risk-free.
Oh, not at all. It clearly impairs driving skills and judgment. It can increase heart rate, which is a risk for people with cardiac issues. And notably, the text mentions a significant risk of precipitating a first psychotic break, like schizophrenia, in adolescents who are already genetically susceptible. And for pregnant women, it's considered teratogenic. It can affect fetal brain development.
What about synthetic cannabinoids? You see these in head shops, sold as K2 or Spice.
These are a whole different beast. The text is very clear. These are much more dangerous than natural cannabis. They are lab-created chemicals, often from unknown sources, that are just sprayed onto dried plant matter. They hit the cannabinoid receptors with massive potency and can have unpredictable effects. We see seizures, psychosis, and severe toxicity with these synthetics that we almost never see with actual marijuana.
Let's move to the next group. Hallucinogens, LSD, mescaline, psilocybin for mushrooms.
These all act primarily on serotonin receptors, specifically the 5-HT2A receptor. The hallmark of these drugs, which distinguishes them from something like PCP, is that they cause profound hallucinations without delirium. The user generally knows who they are and where they are. They aren't confused, but their sensory input is completely scrambled.
The famous synesthesia.
Hearing colors, seeing sounds, it's a literal cross-wiring of the senses at a neurological level.
And what about PCP? Phencyclidine. This one has a much scarier reputation.
And for good reason. PCP is a dissociative anesthetic. It blocks NMDA glutamate receptors, the same ones alcohol inhibits. Users feel completely detached from their bodies, from reality. But unlike LSD, PCP often triggers extreme hostility, agitation, and bizarre violent behavior. They feel no pain and can have what seems like superhuman strengths due to a massive adrenaline release. It's an incredibly dangerous situation for first responders and ER staff.
Okay, Section 7 brings us to a really modern problem. Prescription, OTC, and inhalant abuse. We touched on opioids, but what about over-the-counter abuse? The text specifically mentions cough syrup.
Dextromethorphan, or DM. It's in almost every non-drowsy cough syrup. At standard doses, it's an effective cough suppressant. But at very high doses, it loses its specificity and starts acting on PCP receptors, NMDA, and even opioid receptors. It causes a dissociative hallucinogenic trip.
And Benadryl. I mean, plain old diphenhydramine. People abuse that.
They do. This is an antihistamine. But in very high doses, it causes a state of anticholinergic toxicity. This is not a pleasant high, it's a full-blown delirium. The classic mnemonic doctors use is mad as a hatter, red as a beet, blind as a bat, dry as a bone.
What does that mean?
It means confusion and hallucinations, flushed red skin, dilated pupils causing blurred vision, and dry mouth. It's often mistaken for psychosis in the ER.
Let's talk about inhalants. Huffing, glue, paint thinner, lighter fluid. This seems particularly tragic.
It is, and it's often a pediatric or adolescent issue because these are things kids can find around the house. The text highlights a specific, terrifyingly lethal mechanism called sudden sniffing death.
That sounds like a headline, not a medical term.
It is the medical reality.
Right.
The volatile solvents in these products, like toluene, sensitize the heart muscle, the myocardium, to adrenaline.
What does that mean, sensitize?
It means the heart becomes hyperreactive to it. So a kid is huffing, they get startled by a parent walking in, or they try to run away.
Mm-hmm.
That natural surge of adrenaline hits the sensitized heart, and it can trigger an instant fatal cardiac arrhythmia, ventricular fibrillation.
That is absolutely horrifying.
It is, and that's aside from the long-term damage. Toluene literally dissolves myelin, the insulation around nerves. Chronic users can get permanent brain damage, movement disorders, and dementia.
Okay, we have covered an enormous amount of damage. Now, in the final section, Section 8, we look at the fix, management of drug abuse. How do we treat this pharmacologically?
It's a stepped approach. First, you have the emergency. The patient is acutely intoxicated or overdosing right now.
And we use antagonists here, right? We mentioned one already.
Exactly. Naloxone for opioids, as we discussed. And for benzodiazepines, the antagonist is flumazenil.
But there's a nuance with flumazenil, a warning in the text.
A big one. If a patient is physically dependent on benzos, like they take Valium every day, their brain is adapted. If you suddenly hit them with flumazenil, you strip all the benzos off the receptors instantly. This can trigger massive, life-threatening seizures, so it's used with extreme caution.
After the emergency, you have withdrawal management.
The goal here is to land the plane safely, not let it crash. We use substitution therapy. The principle is to replace the dangerous short-acting drug of abuse with a safer, long-acting equivalent from the same class, and then slowly taper the dose down over days or weeks.
So for alcohol withdrawal,
You give benzodiazepines, like lorazepam or diazepam. Alcohol withdrawal is serious. It can cause delirium tremens, DTs, and seizures, which can be fatal. Since benzos hit the same GABA receptor, they keep the brain calm and prevent seizures while the alcohol clears out of the system.
and for opioids?
You can use methadone. It's a long-acting oral opioid. It prevents withdrawal symptoms without causing the intense high of heroin. Or you can use non-opioid drugs like clonidine, which is an alpha-2 agonist that calms the sympathetic nervous system overdrive, the sweating, the racing heart, the anxiety of withdrawal.
Finally, we get to the long game, treating dependence. How do we help prevent relapse in the long term?
For alcohol, the text details 3 key drugs. First, there's disulfiram, which is sold as antabuse. This works on the metabolism pathway we talked about earlier. It blocks aldehyde dehydrogenase,
It's the second enzyme in the chain.
the second enzyme. So if you are taking antabuse and you drink even a small amount of alcohol, the toxic acetaldehyde builds up instantly. You get violently ill flushing, a pounding headache, intense nausea, and vomiting.
It's a deterrent. It essentially puts an electric fence around the bottle.
A very effective one. Then there's naltrexone. This is an opioid receptor blocker. But clinical trials showed it also reduces the craving for alcohol and, importantly, the reward you get from drinking. It seems to break that positive reinforcement link between the drink and the dopamine release.
And the third one?
Acamprosate. This one is thought to help restore the normal balance between the glutamate and GABA systems, which gets completely thrown out of whack by years of chronic drinking. It helps reduce the protracted withdrawal symptoms that can drive relapse.
For nicotine, we all know about the patches and gum, but the text mentions some pills.
2 big ones. Bupropion, which is also sold as the antidepressant Wellbutrin. It boosts dopamine and norepinephrine, which seems to help reduce cravings and withdrawal symptoms.
Okay.
And then there's varenicline, or Chantix. This is a very smart drug. It's a partial agonist at the main nicotinic receptor in the brain.
What does that mean, partial agonist?
It means it sits in the nicotine receptor and it turns it on just a little bit, enough to trickle out some dopamine and prevent severe withdrawal symptoms. But because it's sitting there occupying the seat, if you then smoke a cigarette, the nicotine from the cigarette can't get to the receptor.
So the chair is taken.
The chair is taken, smoking becomes pointless. You get no buzz, no reward. It makes smoking unsatisfying.
This has been an incredibly comprehensive, and I have to say, fascinating tour of Chapter 25. We've gone from the single molecule to the receptor to the withdrawal ward. As we wrap up, what is the single biggest takeaway for you from this chapter?
For me, it's the profound unity of mechanism. We talked about uppers, downers, hallucinogens, legal drugs, illegal drugs. They seem like completely different worlds, but at the end of the day, They all converge on that dopamine reinforcement pathway in the nucleus accumbens. Addiction isn't 100 different problems. It's one biological lock being picked by 100 different keys.
And that leads us to our final thought. The text kept using that term we started with, neuroadaptation.
Yes. And I think that's the most provocative and honestly the most compassionate idea to leave with. Dependence isn't a failure of willpower. It's not a moral choice. It is a physiological state. The brain is dynamic. It is plastic. It physically changes. It rewires its gene expression. It builds new protein structures in response to these chemicals, all in an attempt to maintain balance.
So when we look at someone struggling with a substance use disorder, we aren't looking at bad behavior.
We're looking at a brain that is fundamentally physically adapted to a new and hostile chemical reality.
A powerful perspective shift. The brain is just trying to survive the environment we put it in.
Precisely.
Thank you for listening to this deep dive into Chapter 25. This has been the Last Minute Lecture Team.
Stay curious.